Good morning. So today, being an Saturday, okay, I thought we have just one day to go, so I didn't start any new topic. So what I thought, one of the important practice oriented session, very important topic is anaphylaxis. So in your practice, as well as when you have appear for your exams, wherever, whichever type of exams, anaphylaxis is one of the most important questions that you have to deal. And anaphylaxis patient, if you are not identifying and not treating properly, the patient is going to die. So we should know how to approach a patient with anaphylaxis. So this anaphylaxis algorithm, whatever you have given, similarly like American Heart Association, for European countries, especially in UK, there is something called as Resuscitation Council UK. So they have come up with a flow chart by which we can easily remember what to be done when a patient is having an anaphylaxis. So this is a pretty simple algorithm. What you have to see here, whenever you have patient with a suspected anaphylaxis, how you have to manage. So that is this algorithm. This is a 2021 updated algorithm. So just 2 years old algorithm. So we'll just see what are the major aspects of an anaphylaxis. So let's see what is anaphylaxis. Can anyone of you tell what is anaphylaxis? Okay, it is an hypertensive reaction. It can be an allergic reaction. You have a lot of definitions for that. So simple thing is that when there is any agent can cause an anaphylaxis. There is nothing like only drugs can cause, only insect bite can cause, nothing like that. Food materials, anything can cause an suddenly and triggered response to the body, and the body can overreact to it, and as a result you can have hypersensitivity reaction, anaphylaxis, leading to airway, breathing, circulation compromise. So anything in this world can cause anaphylaxis. Even drugs used to treat anaphylaxis can cause anaphylaxis. So there is nothing like you have in the world that doesn't cause anaphylaxis. So anaphylaxis can happen at any point of time. So you have to be very clear in managing, because when you not identify that, the patient will die. So that is very important. So you have to first of all recognize an anaphylaxis. Can you tell me one of the common agents that can cause anaphylaxis? Some common examples of some common agents. So we can call it as normal food materials. So what are the common food items that can have history of anaphylaxis? Common, most common. Peanut, okay. Seafood, peanut allergy. Then dairy items, okay. Milk products. So these are some common agents that can cause anaphylaxis. So you have to be very clear when you are at egg allergy. Very common. Egg allergies, some people can have egg allergy. Some people have to milk products, peanut. These are the common agents. But as I said, to any agent, you can develop anaphylaxis. So when you develop this episode, you have to be very careful. When you have developed an anaphylaxis, you should avoid those agents. So that instruction has to be given to the patient once you are discharging. So sometimes you might not be able to recognize what is the allergen that has caused anaphylaxis. So in that situation, it is very difficult. Then there are a lot of blood investigations to find out which is the most potent agent that is causing. But during an anaphylaxis episode, we cannot do all those things. Once the patient recovers from anaphylaxis, you can do all those investigations. But routinely, you cannot do. Then what are the other common drugs that very famous to cause anaphylaxis? Drugs that can very frequently no, most common ones are NSAIDs, then penicillins, sulfa drugs. So these are the common agents that can cause allergy. But whenever you are dealing a patient in your ER or in the ICU, you have to make sure that the drug history or allergic history is very important. It is not just to drugs, also to, they can have allergy to pollen, the woolen clothes they are wearing, maybe to just to the allergy to the common termite what we see at home. So all those things they can have allergy. So allergic history is very important. So whenever you have a patient coming to ER, you always ask for allergy. That is in the sample history we always ask signs and symptoms. Then we have allergies. So these are some common agents that can cause allergy. That's what we have discussed here. Okay. Now, when you have a patient, what are the things that needed to be done? First thing, you have to maintain that airway, breathing, circulation, D and E. A, B, C, D, E. So, A, B, C, D and E. So, A, what all problems can happen to the A? The airway can get obstructed due to the laryngeal edema. So, that is what? The tongue can get swollen up suddenly and it can cause significant edema, and this patient can have obstruction of the airway and hypoxia and cardiac arrest. So, airway is very important. Breathing, they can start with initially, they can in airway and breathing, they can slowly start with stridor, small stridor, change in the voice pattern. So, that will be the first thing. You know somebody's, your colleague's voice, suddenly his voice have changed. You have been having a food in the restaurant, suddenly after having 10 minutes having some food material, your friend sound suddenly has changed. So, there is nothing else he has developed, just the sound change. So, that is an early thing that you are recognizing that this patient is going to have a probable anaphylaxis. So, in circulation again, you can have tachycardia, then hypotension. Very common to have hypotension, and disability due to altered sensorium. Why altered sensorium? You can have decreased perfusion to the brain. So, the patient can suddenly collapse, and there can be profuse sweating also when there is a hypotension. And in exposure, you can have redness of the skin, mucosal membranes, and all this redness, heaves, small heaves, small discoloration, reddish discoloration you will be able to see. So, these are the things that you need to maintain. So, make sure that your airway, breathing, circulation is maintained. Sometimes you need to start them on a surgical airway, needle cricothyrotomy, to suddenly open up the airway because the total upper airway is obstructed. So, in order to that, you have to make a surgical airway by putting in needle jet ventilation. So, these are all things that might be required when a patient is having anaphylaxis. So, how will you diagnose an anaphylaxis? That is the next question. So, the diagnosis can be a sudden onset of airway, breathing or circulatory problem. So, whenever there is a sudden history, you are not sure, he was otherwise able, suddenly happening, always think in terms that it can be a probably an anaphylaxis. Sudden onset breathlessness, sudden onset circulatory collapse, all those things keep in mind, it can be a potential anaphylaxis. And suddenly there is a skin rash. So, this all contribute to a probable, after an insect bite, somebody is coming after an insect bite, suddenly he is having profuse sweating and he is having itching all over the body. So, that is a classical history of anaphylaxis. So, all this history you have to see, and you have to have a probable diagnosis of anaphylaxis. See, some patients can have GI symptoms, they can have diarrhea, soon after consuming they can come with diarrhea and abdominal pain and hypotension. So, it is not gastroenteritis, it can be an anaphylaxis to food that you have consumed. So, they can present with those symptoms also. So, you have to keep those things in your mind. So, you should always have a high index of suspicion of which patient is going to have an anaphylaxis, why he is having an anaphylaxis, what a sudden onset of A, B, C compromise. Always keep in mind whether it can be an anaphylaxis. So, that those things you should, sometimes the patient will not give you any history because he is not conscious. So, we are not able to get anything. You are looking at the airway is all swollen up. You have to suspect and give adrenaline in those situations. So, that is the first thing, and immediately, like for any emergency, you have to call for help. See, remove trigger if possible. So, remove trigger means if you are thinking that you have a patient with snake bite, okay, I am giving a scenario. Snake bite, you have to give anti-snake venom. Anti-snake venom is a protein again. So, when you are giving anti-snake venom, you can have anaphylaxis. So, what you have to do anaphylaxis is that you have to temporarily stop the infusion and you have to treat anaphylaxis. So, the first step in managing any anaphylaxis is that if an infusion is going on, you have to stop that infusion. Suppose you are giving a drug, a penicillin you have given, test dose you thought there is no allergy, but while giving your penicillin augmentin injection, the patient has suddenly developed profuse sweating, redness, and patient is having some suffocation. The first thing, stop that infusion. That is the first thing. Call for help and stop that infusion. So, the trigger should be stopped. So, that is the first immediate action that you need to do. Lie patient flat. The patient is standing like this, make him flat, and with legs elevated. If possible, you can elevate the legs, because why? Because there can be increase in the venous return. So, if the patient is having any hypotension, you can just elevate the leg, and a sitting position maybe make them feel comfortable. Maybe in the bed you can just lift up the head and area, they might feel comfortable during that time. So, whatever be the comfort, you have to see. And if it's a pregnant lady, what you have to do? keep her on the left lateral position, because hypotension again can further worsen. So you have to have the lateral displacement of the uterus you have to do. So that is the initial step that you need to do. So we have done that, and we have diagnosed it is an anaphylaxis. If it is an anaphylaxis, there is nothing else that you need to do. Just give one shot of adrenaline. So what is available adrenaline is 1 in 1000 ml dilution. So in cardiac arrest we used to give IV, but here it is IM. So give IM 0.5 ml of adrenaline. If it's an adult patient, give adrenaline. Where to give, you can inject in the anterolateral aspect of the thigh. So that is the area where you can give. Anterolateral aspect of the mid thigh is the area, the image that is representing here. So you can give in the anterolateral aspect of the mid thigh. So this is the area. Just take this and just give this injection here. So this area you can give the injection, and after that establish the airway. If the airway is not patent, you have to do with what? Try with intubation, or you have to go for a surgical airway during that situation. So these things can be challenging things that you need to have. Maybe you have to give oxygen, apply monitoring. You should not waste time by taking the monitors and all those things. You suspect anaphylaxis, the patient is not responding, you suspect that the patient is having anaphylaxis, pulse is there, give immediately adrenaline. There should not be any delay in giving adrenaline. So after 5 minutes you have given adrenaline, still there is no response, you can repeat one more dose of adrenaline. So you can repeat adrenaline, and also you can start the patient on IV fluids. Because of hypotension there can have, so establish an IV access meanwhile and give the patient on IV fluids, any crystalloids, normosaline or renal lactate. You can give somewhere around 1 liter, 500 ml to 1 liter you can give bolus, and in children you can give 10 ml per kg. You can start with 10 ml per kg. So that is the dose that you need to remember for the children. So what you have done, we have a patient with a suspected anaphylaxis. You have taken care of ABC. If there is an ABC, you confirm that probably it's an anaphylaxis. You give 0.5 mg of adrenaline sub-Q immediately, IM immediately on the anterolateral aspect of the thigh, and that is the first step that you need to do. Then after that you can repeat one more dose of adrenaline, 5 mg, after 5 minutes you can repeat 0.5 mg of adrenaline again, and you can look for any hypotension, and you can correct with fluid boluses. If no improvement in breathing or circulation despite 2 doses of adrenaline, confirm resuscitation team has been called. You have to call the team for help, and you have to hand over to them. So we have not done any IV medications here, only fluids we have started. So there is another algorithm that we will see next. There is a refractory. As I told, what do you mean by refractory? So initial treatment, if it is not responding, we can call it as refractory. So there is a refractory algorithm that I will show you after this. So this is what initially you have to see. And see, what are the life-threatening issues when you suspect an anaphylaxis? That is given here. You can have hoarseness of voice or stridor. Whenever you have an hoarseness of voice or stridor, that is a life-threatening issue. Breathing, increased work of breathing. You see him breathing very fast, increased work of breathing, saturation less than 94%. There is hypoxia. These are all life-threatening signs. And wheeze, you are auscultating, there is wheeze. The patient is fatigued, and there is cyanosis. So these are all signs says that this patient is having a life-threatening anaphylaxis. Circulation, again hypotension, signs of shock, elevated CRT, capillary refilling time. These are all the signs that this patient is having a life-threatening anaphylaxis. So these are the life-threatening signs that you need to remember. So again, coming down here, these are the different doses that you need to remember here. So you can have different age groups. So for an adult patient, it is pretty simple. It is 0.5 ml. Then depending upon the age groups, if it is 6 to 12 years, you need to give 0.3 ml. If it is again 6 months to 6 years, you can just remember half the dose of this. Less than 6 months, what you need to remember is that you can go 100 to 150 microgram per IM you can give, 100 or 150, or you can just remember 0.1 ml to 0.15 ml. Okay, so these are the things that you need to remember. So this is for doses is only for IM. I am just said IM doses only. There is no IV dose here I have discussed now. This is only IM doses I have discussed. So what you have to remember, 1 in 1000 dilution is what is available. 0.5 ml for an adult patient, 0.3 ml for a 6 to 2-year-old child, less than 6 months to 6 year old child, you can give 0.15 ml, and if it is very small kid, you can give 0.1 to 0.15 ml. So these are the different doses of adrenaline that you need to remember. So this is the anaphylaxis algorithm. So as I told, if the patient is not improving after your 2 doses, we can call it as refractory anaphylaxis. So that is called as what? Refractory anaphylaxis. So no improvement in respiratory or cardiovascular system despite 2 doses of intramuscular adrenaline. So we have already given 2 doses of adrenaline, but still the patient is not improving. So what we need to do? So establish a dedicated IV or IVO access. If you are not done, if you have not got an IV or an IVO access, you have to do that, and you have to give rapid IV fluid bolus. If not given, we have already discussed around 1 liter of fluid, that is what you have to give. In a child, you can start with 10 ml per kg. Then what you have to do? We have to prepare for IV adrenaline infusion. Okay, so here we have to give IV adrenaline. So till you are coming back and getting an IV adrenaline, you continue giving IM adrenaline. Okay, every 5 minutes. So what you have done, we have given 2 doses of adrenaline initially, but here you have to start IV adrenaline, but the patient has not started responding. You are going to prepare IV preparation, because you need to break the ampules, you need to get to the syringe and all. Till that time, you continue giving IM adrenaline every 5 minutes until adrenaline infusion has been started. IV bolus of adrenaline is not recommended. Like what we did for cardiac arrest, it is not recommended here. You need to start with an infusion. Infusion protocol I will tell. We will go to that side and I will tell you the infusion protocol, and give high flow oxygen, treat hypoxia, monitor all the blood samples, all those things you can take. And there is something called as blood sample for mast cell tryptase, which is we usually don't practice in India, but in UK there is an investigation that you need to send called as mast cell tryptase. That is to know the degree of anaphylaxis. If the patient has got an elevated this thing, then they are more prone to develop anaphylaxis. That is one investigation, but India we routinely doesn't follow this. So our idea, we have prepared for IV preparation. Now you have to start adrenaline infusion here. So you have to start adrenaline infusion. The simple infusion protocol is that you take 1 mg adrenaline and into 100 ml of 0.9% of sodium chloride. So 1 mg, that is 1 ml of 1 mg of 1 in 1000 adrenaline in 100 ml of 0.9% NS. You can start preparing and connect with an infusion pump via dedicated line. It should not be with another infusion line, because already one infusion is going on. You should not connect to that. It should be a separate IV line for the infusion, and do not infuse on the same side as the BP cuff, because this will interfere with the infusion, right? If the BP is getting reading in between, what will happen to the infusion? The infusion will not go. So 2 things that you need to have: you should have a separate IV line for giving this adrenaline infusion, and you should not be connecting to the limb where the BP is connected. You can change the BP to the other line. That is obviously for all these cases we have to connect to a different IV line. Then in both an adult and children, the dosage is very important. 0.5 to 1 ml, 0.5 to 1 ml per kg per hour infusion. This is the dose. So what you have done? You have taken 1 ml of adrenaline, we have added to 100 ml of normal saline here, and we have made a preparation, and we have to, depending upon the patient weight, we have to titrate, and we have to start on 0.5 to 1 ml per kg per hour as an infusion. That is the dose of adrenaline that you need to start as an infusion. Boluses are not recommended, but in an expert hand situation you might give, but routinely boluses are not recommended. So this is how you need to prepare IV adrenaline infusion. What do you have to take? 1 ampule of adrenaline you take, and you dilute and make it a 100 ml preparation, and you start at a rate of 0.5 to 1 ml per kilogram per hour. So what will happen? No, this 100 ml will have 1 mg, right? So this totally 100 ml will have 1 mg. That's a dilution. No, we are taking 1 ml and adding to 100 ml. So 100 ml will have 1 mg. So each ml will have how much mg? 0.01. So that will be the each ml. So you calculate, you want to start at 1 ml per kg per hour. So it's pretty easy, 1 ml per kg per hour. So 60 kg individual, 60 kg individual, how much ml you need to give? 60 kg, how much milligram you need to give? 60 into 1, if I want to start with 1 ml, 1 ml, so that is 60 ml, that should be given in a minute, right? So into hours, what you have to do? Into 60. So this is what it will come. So this is how you have to calculate. You have to calculate with this formula, 1 ml per kg per hour. This is how you have to calculate every infusions. So depending upon the patient weight, how much ml you need to give, you have to decide. So 0.5 to 1 ml per kg per hour infusion is what? Not minute, per hour. Into 60 is not needed. Sorry, I did a wrong mistake. That into 60 is not needed. It is per hour, right? Okay. So I will just correct you once again. 1 ml per kg per hour, right? Okay. So 1 ml you have taken into 60. That is enough, per hour. It is not per minute. So it will be 60 ml per hour that you need to give. So you have 100 ml will have how much? 1 mg. So 60 ml of this preparation should be going in an hour. If it is minute, into 60, that is a mistake that I have done. It is not into 60, you have to continue, because majority of other infusions are into 60. That's why I got confused. So it is 0.5 to 1 ml per kilogram per hour. If it is per minute, you need to multiply it by 60. So it is per hour. So 60 ml per hour you need to see. If it is 0.5, 30 ml per hour you need to start. So 30 ml per hour. So that is the infusion. So again, I will clarify. So what you have to do, you have to take 1 mg of adrenaline, you dilute into 100 ml of NS, and you give at a rate of 0.5 to 1 ml per kg per hour. So that is the dose that you need to remember. So for a 60 kg individual, you have to start at 60 ml per hour infusion. So you continue the infusion and you look for your clinical response. Clinical response, what all will be the clinical response? Hypoxia is improving. Whether the heart rate, whether there was a bradycardia or the blood pressure is improving. These are the signs of appropriateness. If BP is likely to indicate adrenal overdose, you can continue adrenal infusion and ABC and titrate accordingly. You can decrease. If you are thinking that BP has suddenly shoot up, you can decrease the infusion rate. So depending upon your required clinical improvement, you can decide whether to give more dose or you need to continue. You can start with 0.5, then you can go up till 1 ml. Otherwise, you can start with 1 ml and you can come down to 0.5. So it's all up to you. You can start with 30 ml per hour for a 60 kg individual. Then you can slowly titrate, go to 40, 50 and maximum 60. And if you start with 60, BP is very high, come down 60, 50, 40, 30, like that. So that is what you have to do. Now, there are certain other things that you can do for your airway management. See, airway management, there is a partial airway obstruction. You are having some stridor. The patient is having some stridor. Just what you can give is nebulized adrenaline. You can give 5 ml of 1 mg per ml adrenaline. You can give nebulized adrenaline. So that is one indication where you can give. And there is a total upper airway obstruction. You have to go for surgical airway. So as I told before, surgical airway, needle cricothyrotomy, jet ventilation or surgical cricothyrotomy, all those things that you need to remember. Oxygenation, again coming to B, oxygenation is very, very important. So securing the airway is not our priority. You have to continue oxygenate the patient. Oxygenation is very, very important. So you can consider back mask or tracheal intubation. And if there is severe bronchospasm, this patient is having persistent bronchospasm, you can give salbutamol and ipratropium with oxygen. Salbutamol and ipratropium with oxygen can be given. And again, IV bolus or infusion of salbutamol or aminophylline. If the patient has got significant V's, you can think of starting these things. So that is breathing. Now coming to circulation, as a child 10 ml per kg per bolus that you can give. The preferred is crystalloid. If there is, the patient is refractory to adrenaline. See, you have started adrenaline infusion also, but still there is hypotension. You can consider starting on noradrenaline or vasopressin. So these are the two agents that we will start. Adding a second line agent, norepinephrine, or you can add vasopressin. So these are the other agents that is available. And see the problem, no, some patient will be already on beta blockers. So when you give this adrenaline, there is no receptors for this adrenaline to act. So we have to reverse the action of beta blockers. So what is the antidote of beta blocker? Glucagon. So glucagon you need to give for those group of patient who is on beta blockers, very high dose of beta blockers. Still, this thing is not improving. After giving adrenaline, you have to consider giving glucagon also, which is the antidote for your beta blockers. And if the patient is going for cardiac arrest, whatever we have discussed before, continue CPR, high quality CPR, give adrenaline every 3 to 5 minutes. So that is the additional thing that you need to remember. Okay, so I'll just rush through the algorithm once again. So you have a patient with a suspected anaphylaxis. So when will you suspect an anaphylaxis? Sudden onset of airway, breathing, circulation compromise. Somebody is coming to you with skin rash also. You will suspect that this patient is having a potential anaphylaxis. The patient is having a potential anaphylaxis. Immediately stabilize ABC and do not wait for anything. Give IEM 0.5 ml for an adult patient. Immediately, anterolateral aspect of the thigh. The next thing, what you have to do before that, you have to stop the infusion. The patient is on any infusion, you have to stop it, stop the trigger. That is the major idea. Then, next thing, for a child, what you have to give? You can give, if it is 6 to 12 years, 0.3, 6 months to 6 years, 0.15, less than that, 0.1 to 0.15 ml. Then, repeat one more dose if the patient has symptoms again. So, after 5 minutes, you review the patient, and if the patient has symptoms again, you repeat the dose. If there is associated hypotension, start on crystalloids, normal saline or ringer lactate, 10 ml per kg for a child and 1 liter for an adult patient. Then you assess the patient. If still the patient is in features of anaphylaxis, we will call it as refractory anaphylaxis. So, if it is refractory anaphylaxis, you have to start the patient on adrenaline infusion. So, till the time you prepare infusion, you continue giving IM adrenaline every 5 minutes, the same dose whatever we have discussed. Once the IV preparation is available, how will you prepare the IV preparation? Take 1 ampule of adrenaline, you add on to 100 ml of normal saline. So 1 ml into 100 ml, so 1 ml will be 100 ml will be 1 mg. Then what you have to do, you have to calculate the dose 0.5 to 1 ml per kg per hour. You have to start the infusion. Depending upon the clinical response, you titrate the adrenaline infusion. If it is heart rate, everything is going up, BP is going up, you decrease. If there is no effective response, you increase the rate of adrenaline infusion. The next thing is that if the patient is still persisting to have problems, you can add on a second agent like noradrenaline or vasopressin. Airway management is very important. Start them on oxygen. Nebulized adrenaline is also effective. Sometimes you need to go for a surgical airway. Breathing, maintain oxygenation. Start them on oxygen. Try back mask ventilation. If the patient is not improving, try tracheal intubation. Then if there is significant wheeze, you can start on salbutamol and ipratropium bromide nebulization, or else you can even think of starting on salbutamol or aminophylline infusions. So these are the other recommendations that you can remember. Then the most important thing is that you have to remember that you have to stop the offending agent. So once you are discharging the patient, if it is a refractory anaphylaxis, ideally to get them, any anaphylaxis, better to keep them observation for the next 12 hours. Better 12 to 24 hours in the hospital. The most important thing is while discharging, you have to tell them why they developed this. What are the agents that has caused? If you are not able to identify an agent, they need to identify it later. So these are the common things that you need to remember. So in routine practice, what are the additional things we used to give? Sometimes steroids, chlorpheniramine maleate. That if it is an anaphylaxis, there is no rule. If it is just a basic simple allergic reaction over the skin only, maybe that hydrocortisone and Avil will help you. But the problem with this drug is that hydrocortisone will take 3 to 4 hours for its action. Aminophylline chlorpheniramine maleate also will take at least 15 to 20 minutes. But here it's a life-threatening situation. So adrenaline is the choice if it is an anaphylaxis. Just a simple allergic reaction, just an itching and all those things without any airway compromise, maybe we can give these agents, chlorpheniramine maleate, your hydrocortisone and your Rantac injection and all those things, S2 blockers, but antihistamine blockers. So all those things we can give. But in a routine practice, if it is an anaphylaxis, only drug that is going to help you is adrenaline. So that is what you need to remember. So remember, anaphylaxis, which drug? Adrenaline. Anaphylaxis, adrenaline. These are the things that always you need to remember. This is a very important practical aspect as well as your theory question and viva question. Very important, adrenaline. Adrenaline uses you can ask. So 2 uses we have discussed in the last 2 classes, major uses. One in cardiac arrest and second one is anaphylaxis. These are the major indication for the use of adrenaline. Okay, thank you.